Over to you.
Okay, thank you. Good afternoon, doctors. Welcome to this experience sharing program on managing PPH, case studies from labor room, brought to you by Hetero Healthcare. Hetero Healthcare, as doctors you know, is an innovative pharmaceutical company with 25 years of excellence, 36 state-of-art manufacturing facilities, 300 plus products and portfolio, presence in 126 plus countries, 21,000 employees globally, and is amongst the largest closely held pharmaceutical company in India. Hetero Healthcare is amongst the largest manufacturers of ARV, APIs, and FDFs in the world and is Asia's largest API manufacturing facility at Visakhapatnam, Andhra Pradesh. Hetero Healthcare is 360-degree solution provider, striving to fulfill unmet healthcare needs, reaching to customers across India with wide product range encompassing multiple specialties. Hetero Healthcare pioneers in quality and innovation and has the distinction of bringing 4 biosimilar products to market within 5 years of initiation. During COVID-19 pandemic era, Hetero Healthcare, the pioneers in antivirals, offered oseltamivir, favipiravir, and remdesivir to the patient, because of which in August 2020, Hetero Healthcare received an award of Pharma Excellence for COVID drugs. Today's program, experience sharing program. Today we have got Honorable Speaker Dr. Laxmikant Behele with us. Sir is director Lotus Specialty Hospital, Pune. And with this, I hand over the session to Dr. Behele for his comments, and then sir, you can take over. I'll come in the end for sharing for the questions. You can take over, sir.
Yes. Thank you, Dr. Prashant, for a kind introduction. Okay, so I hope my slide is visible to you.
One minute.
Yes, sir.
Yes, sir, they're visible.
Okay. So
Very clearly.
We'll start now.
Yes.
Good afternoon, dear friends. I welcome you all on the behalf of Hetero Healthcare and myself, Dr. Laxmikant Behele, for giving an overview on the postpartum hemorrhage and my experience sharing with respect to the usage of the molecule Carbetocin in the management of postpartum hemorrhage. The slides are not going ahead.
Yeah, they are not going ahead.
Okay, so it's there, yeah. So to have an overview of the postpartum hemorrhage, now this is something that we as obstetrician are very much worried of, and it's not only India, but all over the world is toiling hard to bring down something called as maternal mortality rate. Now, the most important cause of maternal mortality, as far as the whole world is concerned, is postpartum hemorrhage and postpartum hemorrhage and postpartum hemorrhage again. So, just to have an overview and try and learn something to that we can help our mothers deliver safely and to take care of postpartum hemorrhage and hence in further reduce the maternal mortality rate. In a nutshell, what is postpartum hemorrhage? It is any blood loss to the extent of 500 ml following a vaginal birth, or to the extent of 1000 ml following cesarean section, or to the extent of 1.5 to 2 liters if the patient is undergoing obstetric hysterectomy. This amount of blood loss is quantified as a postpartum hemorrhage. And this unfortunately happens to be the most common cause for maternal mortality in not only India, but all over the world. So as you can see, it is the leading cause of maternal mortality, accounting for almost 35% of all the maternal deaths in the world. And we are toiling hard in order to reduce the maternal mortality rate. The global incidence says that 14 million women suffer from postpartum hemorrhage in a year. And the incidence is to the tune of 2 to 4% following a vaginal delivery, and almost to the tune of 6 to 8% following a cesarean section. Nowadays, with the rising trend of cesarean section due to various causes, we have to take care of postpartum hemorrhage, and then only we can attain our goal of reducing the maternal mortality rate. Now, before going ahead, if you want to look at the various incidents of maternal mortality in India, now I've been through the various figures of maternal mortality rate in India. Our rate of maternal mortality in the recent figure is around 88 per 1 lakh live births. The lowest maternal mortality rate of India is found in the state of Kerala and Andhra Pradesh. It is the tune of around 30, where Maharashtra stands around 38 to 40 per 1 lakh live births. So we are not doing bad, but again, we have to be more cautious and try and reduce even a single maternal mortality so that the figure can come down to a single digit. And that is our motto as far as reduction of the maternal mortality is concerned. How can we go ahead with reducing the maternal mortality? Before that, let us look at the etiology of postpartum hemorrhage. So we are very much aware of the four T's: the tone, trauma, thrombin, and tissue. The tone, that is autonicity, accounts for 70% of the causes of maternal mortality, followed by trauma to the vaginal, to the cervix, or to the uterine musculature, which accounts to 20% of the cause of maternal mortality, followed by tissue, which is 10%, and then thrombin, that is coagulopathy, accounting for just 1% of the maternal mortality rate. It's not always that only a single cause can be there for postpartum hemorrhage and then leading to maternal mortality. It is many times found that more than one cause can be there, which is exaggerating the problem of PPH, and hence the mother lands up with a death. So just to take an example, suppose if there is a patient who is having previous cesarean and undergoing a VBAC, a trial of labor, and unfortunately there happens to be a scar dehiscence which is missed, and then she lands up into actual scar rupture, that uterine rupture. In that scenario, there will be a traumatic PPH which can occur if she is taken up for emergency cesarean or laparotomy and the blood loss is continuing. Simultaneously, there can be superadded autonicity of the uterus because of blood loss. So again, following traumatic PPH, autonic PPH again sets in, and then with the loss of blood, the coagulopathy sets in, and then there can be thrombocytopenia and coagulation failure. So in a nutshell, at times there can be multiple causes superimposing PPH and then leading to maternal death. So how do we come across, how do we diagnose a patient of postpartum hemorrhage? The most common finding is vaginal bleeding. But be aware, many times it's not always that the blood loss is seen outside. It can be there just inside the abdominal cavity through the uterine incision or the ruptured part, or it can be just collection of the hematoma into the vaginal orifice or into the vaginal lumen, and the blood loss may not be always seen outside. So we have to check for the uterine tone and try and press the uterus from the above to see whether there is any blood trickling out of the introitus. Apart from vaginal bleeding, there can be maternal tachycardia, and yes, maternal tachycardia is the first and foremost sign that has to be taken into account if we are noticing a patient who is landing up into a PPH, because once the blood loss is more than 10 to 15% of the blood volume, the patient will manifest into maternal tachycardia, and this tachycardia will try to compensate for the blood loss and manage the blood pressure. If the PPH goes ahead, following maternal tachycardia, there can be hypotension, and then, of course, the various signs and symptoms of maternal shock will set in, and then the patient will go into hypotension, syncope, and then coagulopathy, and then dismal part of the maternal mortality can be there. So if we take into account the first and foremost sign, that is bleeding and maternal tachycardia, and of course shock index, which is very important as far as giving us an idea about the blood loss is concerned, then we can diagnose PPH in the early phase, stage 1, and hence the further complications can be avoided. So PPH can be classified as mild, moderate, and severe. Any blood loss of more than 15% is called as mild PPH, and more than 35 is called as severe PPH. So again, one important factor to be noted here is that it's not that only the quantity of blood loss is important, because as we say in vaginal birth, if the blood loss is more than 500, we classify it as PPH, and whereas a blood loss of more than 1000 ml will be PPH in a patient of cesarean section. But does this particular value also to every patient? It's not so. Why? Because the body weight of the patient is different. It's not the same case when you are dealing with a patient of 50 kg in labor and a patient of 70 kg in labor, because the blood volume of the patient will be different, as we all are aware. So it's about 70 to 75 ml per kg is the blood volume. So if a patient is weighing 70 kg, the blood volume will be to the tune of 5 liters, whereas in a patient who is just 50 kg, the blood volume can be to the tune of just 3.5 liters. So, a patient who is 70 kg will tolerate 500 ml blood loss normally. Otherwise, a patient who is just weighing 50 kg may not tolerate blood loss of even 300 ml. So this is what is important and has to be taken into account when we are dealing with the patient of PPH. So blood volume and the weight of the patient needs to be taken into consideration, and not only the absolute value of 500 or 1000 ml. So as we discussed, the most important sign of PPH is tachycardia, followed by hypertension. Very important to look for the amount of blood loss and quantify it as early as possible so that we don't miss the patient going into PPH. Also look for shock index, and then if the patient, the shock index is going about 0.9, there is an alarming sign, and a shock index of more than 1.2 will be very important, and one has to take action and go ahead with any operative steps which have to be taken to take care of PPH. Now, once you have diagnosed the case of PPH, apart from the clinical assessment, the laboratory assessment is equally important because, as I said, it's not only the hemoglobin, but also the platelets and the coagulation profile will matter, because apart from you taking care of the tone and the trauma part, the coagulopathy should not set in, because in that case, then the management part becomes very difficult, because then not only blood, but then replacement with the platelets and the coagulation factor becomes equally important. And we all know that it's whenever we deal with the case of severe PPH, the massive transfusion protocol will have to be taken into place, and then 1:4 should be the ratio wherein we transfuse 1 PCV followed by 1 platelet and 4 FFPs. So this is what is the basic approach which we follow when dealing with the case of postpartum hemorrhage. So when there is poor uterine tone, as we diagnose when we feel the uterus is flabby or relaxed on abdominal palpation after maybe a vaginal birth or even cesarean section, then we send the lab and take care of. We have already arranged blood for this patient who is in labor. So remember, arrangement of PCV, paxil volume, as the case may be, and then if required, the other clotting factors and the platelets, if required, in case of preeclampsia, is very important in a patient who is in labor. So irrespective of the severity of the case, blood and blood products have to be arranged for every patient who is in labor. And so we manage the case of uterine atony by giving oxytocin in the form of oxytocin, the carbetocin newer analogs. If not controlled with oxytocin, we can go ahead with use of ergot alkaloids and prostaglandins, which are very much useful in management of PPH. In case there is a fear or there is a diagnosis of trauma along with atonicity, so maybe there is vaginal laceration or there is cervical trauma following a big baby's birth, or you have used forceps or ventouse, or in case there is cesarean section and there has been a tear into the broad ligament, or the lateral part of the uterus has been injured, then there can be traumatic PPH, and then accordingly you have to manage the case. So use of ligation sutures, stepwise devascularization is equally important when we are dealing with the case of traumatic PPH. Third cause is the retained placenta or the retained placental tissue. And then if it's not done with, say, use of uretronics, then of course we have to go for manual evacuation of the placental bits or the placenta by MRP under general anesthesia. And in case the patient happens to land up with coagulopathy, as diagnosed by hemoglobin, hemogram with platelet count, hematocrit falling below by 3% or more, and thrombocytopenia along with a deranged coagulation profile will indicate the diagnosis of DIC, and then use of FFP, platelets, and paxil volume is equally important. And then we try and manage the patient to keep her hemoglobin above 8 and platelets above at least 50 to 70,000, so that the coagulation can help and the blood loss can be reduced. So what is the rationale for the development of carbetocin in the patient of PPH? Now, why dealing with carbetocin alone? Because it's very important as a uretronic in immediate delivery. The postpartum hemorrhage is most common. The cause is atonicity, and hence we want to take care of atonicity, and hence 70% of the cases of atonic PPH or PPH can be managed if we have got good uretronics at hand. So we have a better alternative now to the age-old pitocin, that is carbetocin. It's not that pitocin is not in vogue or not useful. but there have been some uh, uh, what we can say some loopholes wherein pitocin was not acting to the mark. It is because if the refrigeration of the pitocin drug has not been taken care of, or if during transportation the cold chain has not been maintained, then our pitocin, the usual drug, can lose its effectivity. And in such times, carbetocin is the drug of choice, where it remains stable at room temperature, has got a longer shelf life as compared to regular pitocin. It has been found that now the carbetocin that is available is heat stable at 30 degrees Celsius also. So we need not use refrigeration for it. This is especially important where in the periphery where there is a shortage of electric supply, and we want to maintain the cold chain where it may not be possible. So there, the heat stable formulation of carbetocin is very much of importance for management of atonic PPH. So when can we use it? Of course, there are various ways of giving it. We can give it at the delivery of the baby, maybe baby's head or shoulder, whatever you prefer to. And it's very important drug to be used for prevention of postpartum hemorrhage and in the active management of third stage of labor. So we have various molecules like oxytocin, carbetocin, and if required, the use of ergotarcolides or prostaglandins as a second line. So there have been some changes made in the our age-old molecule of oxytocin, and then the newer molecule that is carbetocin has come into vogue. What does these changes in the biochemical structure do? The changes in biochemical structure of oxytocin, and that is carbetocin, helps prolong the half-life of the drug, and as on top of that, there is a reduction in the enzymatic degradation of the drug, and hence the activity of the drug is prolonged for a period of 1 to 2 hours. And this is what is very much important for us in managing immediate postpartum hemorrhage. So carbetocin is a synthetic analog of oxytocin. It's used in the prevention of postpartum hemorrhage, especially due to uterine atony, and it's available as a vial containing 100 micrograms of the drug in 1 ml solution for injection. So how does it act? The carbetocin, that is oxytocin receptor analog, binds the oxytocin receptor on the cell membrane. It triggers the activation of phospholipase A enzyme, and there is generation of second messenger like inositol phosphatidyl 3 or diacylglycerol, which causes the release of free calcium from the intracellular stores. And then the calcium released activates the calcium carbidolin complex, which causes the smooth muscle to undergo tetanic contraction and maintain it, and hence the PPH can be avoided. So, what is the evidence of use of clinical evidence as far as the role of carbetocin in the management of PPH is concerned? Now, just to have a brief description of the various drugs, as we just discussed, oxytocin is a cyclic peptide. It's released from pituitary, posterior pituitary. Its use can be either IV or intramuscular route, but the only problem being the storage. It has to be refrigerated to a temperature of 2 to 8 degrees Celsius. When given IV, the oxytocin acts immediately, but being a short half-life of 20 to 30 minutes, the action passes by 30 minutes. So it has to be given in a continuous IV infusion formulation. Rather, when used intramuscularly, it takes a little longer of 3 to 7 minutes to start its action, but then it can last longer for 40 to 60 minutes. The half-life of the drug is just 4 minutes. Oxytocin can be used for induction of labor, augmentation of labor, and prevention and treatment of PPH. As against the newer formulation, that is carbetocin, the synthetic analog of oxytocin is available in 100 micrograms of vial. It can be used IV or intramuscularly. The action starts in 2 minutes when given IV bolus over a period of 2 minutes, and the action is known to last for 60 minutes when given IV. The same drug when given intramuscularly at the delivery of the baby, the action starts in about say 3 to 5 minutes, and the action is known to last for a period of 120 minutes, so 2 hours. So when given IV, the action lasts for 1 hour, and for 2 hours if it is given intramuscularly. The half-life of the drug is 10 times more. So oxytocin last half-life is 4 minutes, whereas for carbetocin, the half-life is 40 minutes. And most importantly, it is a heat-stable formulation. So no need of refrigeration. Of course, refrigeration will help to maintain the potency of the drug. Most importantly, it cannot be used for induction or augmentation of labor. It is only recommended for prevention of PPH. With respect to the treatment of PPH, we are not yet aware of the various dosing schedules that are possible. So presently, it is marketed and recommended for prevention of PPH. So various studies have been performed for the efficacy of carbetocin, and it has been found non-inferior to oxytocin. The most important, the world famous study is the Champion trial, where carbetocin hemorrhage prevention trial, it's called as, wherein 30,000 women participated in over 10 countries, and even India was a participant of the trial. And it has been found that carbetocin, the synthetic heat stable analog, is not inferior to oxytocin in the management of PPH and uterine autonomy. So if we just see the comparison, nowhere carbetocin is non-inferior to oxytocin with respect to blood loss of more than 500 ml or blood loss of 1000 ml in cesarean section. And the anticipation of adverse effects or serious adverse effects is almost similar. So in a way, it is a very boon to us in management of PPH because it's equally efficacious to oxytocin, and even the side effect and the serious adverse effect profile is equivalent to oxytocin. So the conclusion was carbetocin was non-inferior to oxytocin for the prevention of blood loss to the tune of 500 ml or more, and there was hardly any need of an additional neutrotonic agent was required. So various Cochrane review has been taken in view of the role of carbetocin for prevention of postpartum hemorrhage. So 11 studies involving 2,635 women were included, and the author concluded that for women who undergo cesarean section, carbetocin resulted in a statistically significant reduction in the need for therapeutic electronics compared to oxytocin. Also, carbetocin was found to be associated with less blood loss compared to symptometrin in management of PPH in either vaginal or cesarean section. And of course, there were fewer side effects as were found with either symptometrin or prostaglandins. So, what are the various guideline recommendations for the use of carbetocin? Nowadays, almost all the various societies all over the world, be it WHO, the Canadian Society, the RANZOC, that is New Zealand Society, the FIGO, and even Fox have come up with the guidelines saying carbetocin is the drug of choice now, along with oxytocin, for the management of PPH. So if you are using carbetocin alone is sufficient in the dose of 100 micrograms, available as 1 ml vial, and it has to be given IV slow bolus over a period of 1 minute. So now just to have some discussion about the various cases which I have used carbetocin, and it has been found to be useful in a simple low risk case and even in very high risk serious cases also. So just to highlight, a patient who was primigravida, a full-term pregnancy, came in active labor, and she had a vaginal birth, a low risk patient. It was a 3 kg baby delivered with episiotomy in the second stage of labor. In this patient, we used injection carbetocin 1 ml. Slow IV was given over 1 minute. And to our surprise, rather, we found that the blood loss was almost the tune of, say, 100 to 200 ml. And there are no need of any either second eutotonic, and the patient was doing well in the first 24 hours. So the patient had no extra bleeding, and the tone was maintained over a period of first 1 to 2 hours, following which the patient was comfortable and no PPH was found. Able to second case in a patient who was taken for emergency cesarean section. She was a G4, P1, L1, and E2 with 39 weeks of pregnancy with previous 1 LSCS. She came with complaints of PV leaking with a floating head. So likely the cause was inhaled CPD, and hence the patient was taken for emergency cesarean. Again, after the delivery of the baby, the anesthetist gave injection carbetocin 1 ml, slowly diluted over 1 minute after the delivery of the baby. And again, there was no extra blood loss. The blood tests were hardly to the tune of, say, 250, 300 ml. The patient did not require any second eutotonic. Of course, because it was cesarean section, we wanted to be more safe and secure. We did put 2 tablets of misoprostol, 400 micrograms per rectally after the case was over, and the patient went home uneventfully without any extra loss of blood. Now, this was a case 3 wherein it was a high-risk pregnancy. She was G4 with the previous 3 spontaneous miscarriages, known case of type 2 diabetes mellitus. When investigated for the previous 3 miscarriages, the patient was found to be phospholipid antibody positive and hence was put on ecosprin and low molecular weight heparin 40 milligrams subcutaneously daily throughout the pregnancy. She unfortunately developed severe preeclampsia during pregnancy at 29-30 weeks of gestation, and hence, being a high risk case, type 2 diabetes mellitus, papilla positive on LMWH, and preeclampsia. Once we had achieved 37 weeks of pregnancy, we did post this patient for elective cesarean at 37 weeks. And again, this patient was given carbetocin injection, 1 ml, slowly diluted IV over 1 minute. And because even in this case also, we didn't have any extra loss of blood. The blood loss was only to the tune of say 300, 400 ml, and she did not require any even blood transfusion as such. So this was my experience with the use of carbetocin and my knowledge with respect to oxytocin, carbetocin, and the management of PPH and atonic uterus, and hence in the reduction of postpartum hemorrhage and hence maternal mortality. Thank you very much for your patient hearing. Dr. Pashan, over to you.
Sir, if you can stop sharing, I will bring the panel questions.
Okay.
Yeah.
Yes.
You can see, sir.
Yeah.
First question is, what is the patient profile where doctors can anticipate a PPH?
So, PPH now actually it's not that it cannot occur in a low risk patient. It can occur in every patient whosoever is in labor. So, be it a low risk patient or high risk patient. But then there are of course some factors where we can anticipate PPH, like say elderly primigravida or a very young primigravidas. Those who have got higher weight like obesity, with risk factors of anemia, preeclampsia, big babies in the diabetic mothers. Those who have got say polyhydramnios, those who got twin pregnancy, patients with fibroid uterus, patients who are on anticoagulant during pregnancy, like say LMWH. So these are various patients who can end up with PPH. Of course, placenta previa and the placental cause like previa and abruption, both are again the risk factors where the patient can be in a risk of PPH.
Correct. And in which patients would you prefer to use carbetocin over oxytocin or other drugs for prevention of PPH?
So truly speaking, nowadays we are almost 100% of times using carbetocin and or oxytocin. Yes,
How long
because
you have
it's
been
very
using? How long you have been using carbetocin, sir?
almost maybe 4 or 5 years now.
And general route of administration is
We
intravenous?
use it IV. We use it IV. Be it vaginal delivery or in cesarean section. After the baby is delivered, we dilute it to say 5 ml or 10 ml because we want to give it IV.
Correct.
We give it IV slowly over 1 minute, and that's it. The patient is stable, no side effects.
Correct.
Good uterine tone is obtained. And then once the tone is good, then we can manage the patient if there is any tear or so. And then, so hardly there is any need for second uterotonic.
Can we use carbetocin in case of retained placenta? Any experience, sir?
Yes, no problem.
No problem.
See, the retained placenta will have to be managed by manual removal of placenta.
Yeah, correct.
The case will have to be done under general anesthesia. Correct. Instead, when there is general anesthesia, we fear more that the patient can end up with postpartum hemorrhage.
Relaxation of uterus.
Yeah. So once the placenta is removed and it's evacuated, rather it's separated from the uterus, and with your hand inside the uterus, you can simultaneously start the patient on carbetocin drip, or maybe start giving IV slowly. And slowly, once the uterus is seen grabbing your hand, try and remove the hand. Once the uterus grabs your hand, and then slowly remove your hand, see that the tone is maintained by your one hand on the abdomen. So it's very well of use in retained placenta. No problem.
And in case of Rh negative mothers?
No issue.
This could
Only
be a problem.
thing is that here you have to see for the blood group of the baby, and if required, then the anti-D will have to be convinced. Otherwise, there is no issue. There is problem with argotamine or other argot alkaloids in Rh negative mothers, but there is no problem with carbetocin. It's very well used.
Can a doctor use carbetocin for prevention if oxytocin used for induction? Almost everyone uses oxytocin for induction.
Yes. So carbetocin is not available for use in induction or augmentation of labor. So there oxytocin has got its role, in which we all use it. But then if the patient is already on oxytocin, still carbetocin can be used for the prevention of PPH. There is no problem. If you're comfortable, you can use again the same oxytocin that was there. The drip can be added, and the higher concentration of oxytocin can be used, but there is no problem in using carbetocin, even if you have used oxytocin for labor induction or augmentation.
In which, of course, you prefer all cases IV, but is there a place
Yes,
for IM according to you?
it's up to you whether you're comfortable with your
Okay,
comfort matters or your anesthesis
depends. Correct.
matters. But we usually go for IV route.
IV,
It's
correct.
very well tolerated, no side effects have been seen.
Correct.
If you want the action to be for longer time,
Ah,
then you can use
I,
intramuscular route because it will last for
yes,
120 minutes.
yes.
Where IV action the route will last for say 60
One,
minutes.
one, yeah, 1 hour.
There is a difference.
If the patient is not responding adequately with carbetocin, what other uterotonics you would use additional? I
So
mean, of
here
course,
comes the role of
everything.
so this is the patient where we expect that the patient is rather we worry that the patient is likely to go into postpartum hemorrhage. So
Yes,
there can be likely atony or even other additional factors. Then again we have to now we it's not there you can wait. Here you have to take the help of other uterotonics immediately to take
immediate.
care of the atonicity. There, of course, you can use say argotalcolides like ergotamine or methyl ergometrin if there is no contraindication like say preeclampsia or eclampsia or Rh negative mother. Otherwise, you can use misoprostol or
Prostaglandin.
prostaglandin if required.
Yes. Or other uterotonics advantage of carbetocin?
Again, as the age-old oxytocin helps, this is has got very minimal side effects. We have hardly encountered any available for IV use,
Sir,
and
with oxytocin, have you seen any ADH-related side effects?
very rarely.
Yeah.
Sometimes the patient lands up with when used in higher concentrations for a long period of time.
Ah,
So if you have used maybe 2 to 3 liters of oxytocin in IV
okay,
fluid,
okay.
there the patient is at risk of landing up into pulmonary
ADH.
edema.
Okay.
So there you have to be very watchful, or even, but no such problem will occur with carbetocin because
Carbetocin.
a small volume is given in IV bolus.
Should it be kept as a reserve drug or a first line? You have been using it as a first line, of course. You have already
Yeah,
answered this.
for us, we are using it first line since
First line.
almost 4 or 5 years now.
First. And why keep it for reserve now if the effect is good, if the, I mean,
Anytime,
action,
yes, yes,
yes,
because we want to prevent PPH, and why
absolutely.
to keep it as it? We have got other drugs which are
Correct,
as a reserve, like
correct,
say methyl ergometrin or
correct.
prostaglandins.
Prostaglandin.
So better to use it as
First
equally
line.
as oxytocin.
So in your case, role of anesthetist vis-a-vis gynecologist.
Usually, it's a gynecologist who should decide because anesthetic is not much aware of various risk factors that the patient has gone through. We have seen the patient during an antenatal period, even before the pregnancy, so be it
Yeah, yeah,
IVF or
correct.
whatever. So we are very much aware which patient is at very high risk of going into PPH.
And a
The anesthetic
gynecologist,
comes for the case, so he's
yes.
not much aware.
A gynecologist has seen the patient over 8, 9 months, so he has the
So anytime
complete
he
view
is the
of
one
the
who can decide, of course. Or he should guide the anesthetists for the use of
anesthetic.
carbetocin.
And sir, to conclude, what is your overall experience, your take-home message for the audience?
It's a very good drug. We are all driving very hard to reduce the atonic PPH and hence the metal mortality. So, yeah, and of course, it's a equally effective drug with minimal of side effects. So, as far as the side effect profile and the safety profile and the efficacy is concerned, carbetocin is at par with oxytocin. Very well can be used as a first line drug for prevention of postpartum hemorrhage in the patient of labor.
Right, sir. Thank you so much. It was indeed good, your clinical experience, and you really have been using it for past 4, 5 years. So it's
Yeah,
your experience which matters to the audience. हे रेफरन्सेस किती असले तरी आपल्या डॉक्टरांचे रेफरन्स वेगळे असतात. And
very
it gives
important.
them a lot
Yes,
of
yes.
confidence. Yes. Thanks so much. And we'll
Thank you.
sign off. Wish you a very happy Diwali, sir.
Thank you. Thank you, all of you.
Yes.
Same to you.
Yes. पुण्यात एकदम दिवाळी वातावरण असेल ना आता.
हो हो सुरू झालं सगळं.
Okay. Huh?
Thank you.
Bye,
Bye.
sir. You can sign off.
Bye, Bivas.
Thank you. Bye bye.
Thank you. Bye.